Good afternoon, and welcome to August expert panel discussion brought to you by Inspire Respiratory Critical Care. I want to welcome all of you. And as usual, I want to just quickly go around the room and introduce ourselves. Tom?
My name is Thomas Prano. I'm a respiratory therapist in Canada.
John?
John Encroft, flight respiratory therapist, Orlando, Florida.
Troy?
Respiratory therapist, Columbia, Missouri.
Madison?
I'm an RT at UVA in Charlottesville, Virginia.
And my name is Keith Lamb. I'm a respiratory therapist, also in Charlottesville, Virginia. So just a couple like housekeeping things. I think one of our panelists is going to join us here in a few minutes. Andy Klein from Rush University. Housekeeping. As usual, this panel discussion will be recorded and placed on our YouTube site. And you can get to that via our website, which Madison will put in the chat for us, so anybody can just follow that or write it down. So today's also on our website, you can get to all of the previously recorded episodes and a lot of other different resources, helpful resources and papers and literature and things like that. So once Madison puts that up, go ahead and try to get there and check it out at some point in time. Welcome, Andy.
Thank you so much. Thanks for having me, everybody.
Want to introduce yourself real quick?
Yeah, sure. Sorry I was late finishing another meeting. I'm Andy. I'm a respiratory therapist. I work at Rush University Medical Center in Chicago, Illinois.
Excellent. Thanks, Andy. So today's, we've done this a couple of times now where we've taken a topic that's really complex and sort of broken it up into different parts. Actually, previously, it's been sort of incidental in that we've gotten through our hour and realized that we hadn't covered everything that we needed to cover. And so then we have a part two. We're doing a little bit better in terms of the planning stages here. And so we are confident that we have enough stuff to spread out over at least two different parts. And so today's part one on acute respiratory distress syndrome, we will talk primarily about what is it, what causes it, what are the different etiologies, the primary and secondary, et cetera, et cetera. Lots of things to talk about. But we're going to talk about what ARDS is and how it's diagnosed. What is it that we look at to sort of figure out what is going on, causes, and maybe more importantly, some risk factors that may not be as commonly understood. And then finally, recognize the signs and test results that help identify ARDS in patients. And we'll look at a little bit of a couple of images and things like that. But as you know, if you've ever been to one of our panel discussions, we primarily just talk about the topic. And in front of you here, you have a very diverse group of experts from all different perspectives of respiratory care and more specifically critical care. So we will go ahead and get started talking about describing what ARDS is. Acute respiratory distress syndrome is a syndrome, as the name suggests. And a syndrome simply means that there are multiple parts, multiple aspects of an illness that sort of have to coexist for you to say this is ARDS. And so we'll look at what those things are. But the broad definition of ARDS is sort of an exaggerated inflammatory process, right? So I like to, as a matter of fact, I had a conversation this morning with an individual, and I sort of like to liken it to a bee sting. You know, you have some folks that if they get stung by a bee, they literally don't survive that bee sting. And then you have some people that will get stung by a bee and it just annoys them, right? And so there's a wide variation between those two instances. And in fact, we don't know how a person is going to react to an inflammatory insult, whether or not they're going to have this exaggerated inflammatory process, which turns into ARDS, or if they won't. So the things that we look at, we're going to look at the definitions. Troy's going to go over the definitions here in just a moment. But those definitions go way back into the 70s when sort of people started to really look at during the Vietnam War, and people were getting super sick, and they started to put two and two together, and they're like, okay, well, once somebody's exposed to this, then they have this acute inflammatory process, which results in this. And we can see that on imaging. We can see that on gas exchange indices and other things. And Troy's going to go over that in just a moment. So we'll go over the definitions and how the definitions have sort of morphed into what we think the definition of ARDS is today. And some of these indices that we look at are more useful for researchers than they are necessarily for clinicians at the bedside taking care of the patients. But again, we'll talk about that in more depth here shortly. So again, ARDS, Acute Respiratory Distress Syndrome, is a syndrome that has certain components that have to be met. Essentially, it's this exaggerated inflammatory process, alveolar capillary membrane damage, increased permeability, which results in leaky capillaries, which results in pulmonary edema, which may impinge on gas exchange and decrease compliance. Troy?
Yeah, this is really one of the first papers describing ARDS. Like Keith said, it's been coined different terms over the years. This is a paper by Ashbaugh in 1967 where they described respiratory distress syndrome in 12 patients that was manifested by acute onset of tachypnea, hypoxia, and loss of lung compliance after a variety of stimuli. And they noticed the syndrome did not respond to usual and ordinary methods of respiratory therapy. The clinical and pathological features closely resembled those seen in infants with respiratory distress and to conditions in congestive atelectasis and post-perfusion lung. I became a respiratory therapist in 1982, and although we made some strides in decreasing mortality with ARDS, in my opinion, it's still unacceptably high. You can advance to the next slide.
Yeah, right around the time that this paper was published was when they first started experimenting with the application of PEEP for the first time as well, and just describing in publications literally within a year of this paper that it may be something that should be considered as helpful in these patients. And I would argue that even to this day, we still don't know the best way to to use PEEP in an ARDS patient, but we certainly know that PEEP in general is better than having no PEEP in these patients.
So they tried to get a consensus in 1994. This is the American European Consensus Conference, and they tried to get a definition of what ARDS, and in this one, which was the first one I kind of worked under, that you had to have a acute onset. So the timing has been the same. It has to be an acute onset of bilateral infiltrates. Here in 94, we're still using a fair amount of Swan-Ganz catheters. And you know, back in the 80s and 90s, almost everyone had a Swan-Ganz catheter. And if the pulmonary capillary wedge pressure was high, then it was cardiac related. If it was low, it was more likely to be ARDS. But in this definition here in 94, they have the pulmonary artery wedge pressure as a diagnostic criteria. Then oxygenation, of course, and they described acute lung injury here. They had a section with acute lung injury with a PF ratio less than 300, down to about 200, and then anything less than 200 they classified as ARDS. Anybody want to comment on that definition or anything about it?
I think, if I could, I think it's interesting. I do remember the day of the PA catheter, and it's frequent use. I think that interestingly enough, back originally they made a big deal. People that were thinking about this and talking about this made a big deal about how it couldn't be heart failure, right? This the imaging that you would see with diffuse alveolar edema could be heart failure, and they wanted to make sure by looking at least in part by looking at wedge pressures to make sure that your findings, your gas exchange interruption, and your imaging weren't solely because of heart failure. And in fact, that would not be ARDS, right? So subsequent to that, people started to realize that, listen, these people, a lot of these people that have ARDS also have sort of a heart failure component. And that may be intrinsic or some sort of native heart failure that was pre-existing, or it could be sort of heart failure based on or caused by massive volume resuscitation that a lot of these patients were getting anyway. So I think it's interesting where we sort of downplayed the PA cath. And of course, the part of that could have been because the people just weren't putting them in as often anymore. And so, you sort of try to make that less of an issue.
Sure.
Yeah. The other important thing is that they required the application of PEEP at a minimum of 5 prior to this definition, because they were trying to avoid people saying that there was issues with alveolar infiltrates or edema not fully explained by cardiac failure, but could be explained by the possibility that they were not using PEEP. Interestingly enough, this was 2012, and they were just trying to do this. However, fast forward a number of years, now we have this the inclusion of high flow nasal cannula starting to, should we not call it ARDS because we're not intubating the patient, whereas you have patients with PF ratios of 120 on high flow nasal cannula of 80%. Like, is this not ARDS? So we've definitely transitioned. Most of the guidelines now are trying to include acute hypoxemic respiratory failure, again unrelated to cardiac issues, but they're being a little bit more lenient with this requirement of PEEP simply because we think that high flow nasal cannula should be included, since we are using it on more and more patients that would have otherwise probably been intubated and fell under this category of ARDS.
Yep. Go back a slide. Yeah, the 2012, the Berlin definition came along, which really we're still functioning under. We'll talk about that in a second, but a lot of things stayed the same. It had to be timing within a week of an insult, bilateral infiltrates. The origin of the edema couldn't be completely explained by cardiac failure. And then they classified ARDS into mild, moderate, and severe based on PF ratios, with less than 100 being severe, 1 to 200 moderate, and 2 to 300 mild ARDS. And they added the PEEP here, greater or equal to 5, which wasn't there on the 94 American European definition. Okay, you can go ahead and advance. In 2023, this was proposed not really as a replacement for the Berlin definition, and you can correct me if I'm wrong. I think this was more to complement the Berlin definition. But we have a new global definition, which Tom was talking about, added some things here. The timing still has to be within a week. The origin of the edema also stays the same. The radiologic features, they did add something here, and we'll talk about that in a second, but they added lung ultrasound by a trained professional as a way to diagnose lung infiltrates. And then under hypoxemia, you can see that the mild, moderate, and severe are the same, but they've added high flow nasal oxygen with flow rates greater than 30 liters. And they've also added a category SpO2 to FiO2 ratio less than or equal to 315. And that being with making sure that your SAT is at least less than or equal to 97. As we all know, the oxyhemoglobin dissociation curve, there's a wide range there of oxygen that can occur on that high end. So you have to have a SAT 97 or less. And anybody want to compliment? I'll talk a little bit more about it on the next slide, but is there anything else anybody wants to point out here?
I think you're right, Troy, in that this was a complement to the Berlin definition. And irony or not, but it seems driven obviously by the global outbreak of COVID that we experienced in 2020, 2021, and started to taper off in 2022, only to have this new global definition in 23 come out to include high flow nasal oxygen and lung ultrasound, which you do see a lot of respiratory therapists partaking in now with lung ultrasound pathology, and being able to identify those differences when it comes to infiltrates and what the lungs look like with this insult. But that being said, again, as Tom had pointed out previously, we did see a lot of high flow nasal oxygen, not just in COVID, but I think COVID really kind of highlighted that. And I think this is kind of driven by that outbreak.
I would agree as well, John. I think definitely the existence of COVID and how we were managing patients. I mean, initially most places were scared to use high flow and we're going straight to intubation. But once we realized it was a good solution, we started switching to high flow nasal cannula. And definitely this pushed people to say, listen, this clearly, these patients would be labeled as ARDS if they got a tube and were on a PEPA 5, clearly. I think it started to gain a bit of traction that maybe we should include them when the Flurali trial was published in 2015, when they showed that the more sicker, like the patients with PF ratios less than 200. So the worse your PF ratio, the more likely you were to have a higher survival benefit with high flow nasal cannula. So this is when they clearly thought that this is something that probably should be considered as something that could avoid intubation in patients that would immediately be labeled ARDS the minute they had a tube in place. But COVID made it so it essentially became a non-issue. Like, this has to be addressed now because we knew that COVID was ARDS. Like, as soon as you put the tube in, they follow that criteria regardless.
Sure.
So I think that was definitely the push to just say, listen, we really have to include this now, rather than just thinking about it prior to that when the Flurali trial was published.
Yeah, and I think, Tom, too, to expand on that, I think COVID aside, I think, and I'll speak for my facility and all the ones that I'm affiliated with, but I think we as a medical society work really hard not to intubate people just in general. So if you're waiting to start all of the things that we know, and I'm sure we'll get into this later, but all the things that we know are important to get on board with ARDS in terms of medications and therapies, I think the earlier you can start those, the better these patients have a chance to do. And I mean, if you're going to wait until they're all the way down to sick enough to intubate, and by then you've already lost some of your lung volume, you've already lost, some of your gas exchange. So I think getting them diagnosed early becomes very important, regardless of the underlying cause of the ARDS.
Yeah, and I think we should point out that these studies, even the Flurali one that I mentioned in 2015, they only included acute hypoxemic respiratory failure patients that weren't hypoxic secondary to COPD exacerbations or cardiac failure. So they were taking elements of the ARDS criteria and saying, listen, we don't want to include these patients that wouldn't be included with ARDS, but because of this strict definition of PEPA 5, we can't call this ARDS. So we're going to call it acute hypoxemic respiratory failure. So regardless of definitions being used or not, I think the move forward is to say, listen, if we're going to study ARDS as a problem, perhaps we shouldn't leave out these patients in these studies. Whereas right now we have studies of acute hypoxemic respiratory failure, and then we have ones of ARDS. I've noticed a trend, however, in some current mechanical ventilation studies that are no longer, the enrollment criteria is no longer ARDS by any definition. They are going more towards this acute hypoxemic respiratory failure, not explained by cardiac, basically the pulmonary edema statement there, and also the timing. So this has to be early onset, but they're just getting away from classifying the actual definition of ARDS. For example, there's driving pressure studies that are now including patients that are hypoxemic, but not specifically saying they have to meet a strict definition of ARDS as per any of these publications we're mentioning that define it.
Yeah, I will also say, if you make a mistake, it's not ARDS, you can always reverse course. The earlier, the better that you recognize that there might be a problem, the better off you're going to be in the long run. And just to throw this out there, what do you folks on the panel and anybody else that's listening Is anybody looking at patients on non-invasive and saying, hey, this patient has ARDS? They're on non-invasive and requiring more than 5 a PEEP and 80%. Anybody classifying?
I think, you know what, Troy, that's a great point. And I know Tom had done, I believe it was in Indianapolis, Tom, you did a nice lecture about non-invasive respiratory support and when, when do we pull that trigger? And that's why I have to think that this is, we have to look at ourselves now and iatrogenic injury when it comes to ARDS. And, you put these folks on non-invasive respiratory support and you let them marinate for 3 days on an FiO2 of 100% in these crazy settings. And we talked about P-Silly in one of our previous panel discussions. And so you kind of have to think about that. And is that contributing to what we are now calling ARDS? And, you said early on, Troy, and you're absolutely right. Early on is correct. But then we talk about an insult to the lungs within 7 days. And we get these patients at 5 or 6 days into their insult. They're hypoxemic. We have to put them on some crazy nuclear settings. Next thing you know, they're getting intubated and we're already a week behind the 8 ball. So It gets tough for us as a community to try and treat these patients. That's why we're still flirting with a 40% mortality rate, because I don't think we do them any justice when we sit on them for 3, 4, 5 days on crazy non-invasive settings.
Yeah, you've highlighted sorry, go ahead, Madison.
Oh, sorry, Tom. I would say just real quick at UVA, we have a pretty low threshold for intubating people that are in respiratory failure that are on non-invasive. I would say
that's how it should be, Madison. You're right.
Yeah, and I came from a place where it was kind of the opposite, different patient population, but I would say that I think that the team especially all feel better about the decision to intubate those patients a little earlier instead of just watching their blood gases get worse and worse.
Yeah, I think you both highlighted the point, and I think this got worse with COVID. I think in my lecture that you referenced, John, I mentioned the fact that we used to have some pretty significant and very straightforward criteria for when we should intubate. It was obviously up to a overall clinical decision by the team, but there were multiple factors that were included, and then it usually led to intubation. Now those, all of a sudden during COVID, those multiple factors were being ignored because we're like, well, if we just wait a little longer on high flow, I've seen patients turn around. So we always compare it now to our own personal bias, where we saw someone who was probably otherwise healthy come around the bend just by being treated with high flow nasal cannula at high settings for 6-7 days. But then you have patients that were on 6-7 days that have some underlying conditions or are just overall just weak and tired after a week of breathing heavy with high flow nasal cannula or even NIV. And then by the time you intubate them, their lungs are rock hard. And so I think the pendulum swung completely the opposite direction. At first it was like intubate everybody, don't use high flow. Then it was like use high flow until they basically arrest almost, and then we have so much trouble ventilating them. So, and there were a few studies looking at early versus late intubation, and it was sort of unclear. Some studies showed that early was better. Others showed that late was no different. It depends on how they classified late versus early. So if anyone in listening does look up studies of early versus late during COVID, make sure you look at the definition of what late was. In some studies, it was 48 hours was considered late. In some studies, it might be 6 or 7 days. So just make sure you're comparing apples with apples if you're going to look at the differences in the data out there.
Yeah, and these real sick patients that we referenced in these non-invasive cohorts, they were failing almost 90% of the time. And so when we have those statistics on our side, why are we continuing to turn a blind eye to putting these patients on positive pressure with PEEP and hopefully fixing them, as opposed to leaving them on non-invasive, with FiO2s of 100% and crazy EPAPs and saying they'll get better 3 days later.
I definitely think we lost some focus there for sure. Having said that, I will acknowledge for those sites that were resource limited, for example, they didn't have literally any more ventilators to use on people. This was obviously a horrible situation to be in, and you understood why perhaps they were sitting on some patients if they had a very minimal supply of ventilators. But so we will just throw that out there and acknowledge that we understand that this may have been out of the control of some clinicians. But I think for those of us that did have an option to utilize a ventilator, I think some people just got way too comfortable ignoring the traditional criteria for intubating patients.
And then also anecdotally, we all know patients that were on non-invasive that came through, and you think, well, maybe this next patient will come through, and which probably the majority of patients, that is not the case. But, you always think about those 2 or 3 or 4 or 5 patients that you milked along forever and they actually got better. But I agree with you folks. You shouldn't be messing around that long. Once you did intubate those people, you couldn't keep their driving. You couldn't have lung protective strategies at that point. They were far gone. So
Yeah,
whenever you go ahead.
I just like to reemphasize what you all are saying, but in my mind, the rules don't change just because you're non-invasively ventilated versus you're intubated and ventilated. Like, we're not going to get into these rules today, probably. That's more of a management strategy topic. But people that are on 100% FiO2, people that are on high EPAPs, people that have high respiratory drive, all these things we'll talk about in part 2, but all these people are at very high risk of getting sicker and having ventilator-induced lung injury or support-induced lung injury, in addition to patient self-induced lung injury on non-invasive ventilation. One of the interesting things about the definition is, and I sort of had forgotten about this example, but it's one that I like to teach people when I'm talking about ARDS. And the definition is, you could easily have a patient out on the general ward, right, that's on a 6-liter nasal cannula that has PF ratio, or that has a PO2 of 50. That now, if you solely look at and that might be what they walk around in the mall at, right? This could be somebody who's chronically hypoxemic, and their PF ratio is moderate ARDS if you look just at the PF ratio itself. So there are patients that certainly fit part of the syndrome definition, but clearly don't have ARDS or just chronically hypoxemic.
Yeah, and this is why every definition comes with many publications criticizing the definition,
Right.
because this is always the context of the patient obviously matters when we just look at numbers.
But when you're looking at everything, you got the PF ratio of 60, you got the X-ray that we'll show here shortly.
Yeah,
you have the
in light of unmanageable work of breathing, there's so many
patient came in
factors.
with pancreatitis. This is an ARDS patient of the fullest extent. And
if you just went by PF ratio, you'd be surprised how many patients would get flagged by your EMR and they're just on nasal bronchs. It's definitely context. Context means a lot.
You can go to the next slide. Yeah, and I will say one other thing. Although ARDS is associated with high elastance or low lung compliance, you notice it's not part of any definition. There must be a reason for that. But the rationale for the new global definition that was proposed as a complement to the Berlin, we already talked about the expanded use of high flow. The use of the SpO2 FiO2 ratio in lieu of just the PF ratio, which is it's not always feasible in resource limited settings. Not everybody has a blood gas. The same with the ultrasound. I think, again, you folks mentioned during COVID, there was a lot of resource limited settings. So I think that is a very reasonable thing to add. And then the new category for non-intubated patients. Limitations that all these haven't, been validated in large, diverse studies to predict the validity. The adoption in clinical practice may vary due to differences in training and potential for overdiagnosis. But again, I'd rather be wrong that the patient had ARDS and make some interventions early and then change the plan a day or two in. But just a kind of a course from the American European to the Berlin, and now this, just a few things to think about.
Yeah, and to comment on your point about compliance, Troy, they had considered utilizing compliance in the Berlin definition in 2012. Not only the Berlin definition paper, but there was a follow-up paper or a sort of explaining the rationale for some of the decisions. And they do explain that The addition of compliance, for example, they did note that there was significantly higher mortality in patients with a compliance less than 20 mils per centimeter water. For example, I don't know if that's exactly the number, but they had a threshold number where it clearly distinguished like worse outcomes than not. But the predictability, I think, was in question. Like overall, the predictability utilizing compliance didn't really predict outcomes overall. But when I first saw the paper and I saw them mention that compliance, I was actually surprised. Having said that, anyone clinically working with a patient with a compliance of 20 mils per centimeter water with ARDS darn well knows that this patient is a different beast than someone perhaps with the same PF ratio, but 40 mils per centimeter water. Like we clearly know that there's a more of a gas exchange problem, and it's not so much that the lungs are completely destroyed. So this compliance definitely plays a role, and they do mention that in the paper that talks about the rationale. It says it doesn't, even though they didn't include it, it doesn't undermine the importance that compliance plays in understanding the severity of the patient.
Right. I mean, I think that compliance is sort of like the PF ratio in a sense, in that there are certainly people that run around, the 90-year-old with kyphoscoliosis and that has decreased chest wall compliance, that you intubate them and you may be surprised at how low their compliance is, but doesn't mean that they have ARDS, right? And so we know as clinicians, we all sort of know that this is ARDS, again, based on the combination of different indices that are not normal.
And perhaps we would understand the severity based on the patient if we knew what the compliance was outside of hospital
Before, right?
Yeah, before. Like we don't know, is this a reduction? Like is there compliance? Is there lung compliance when ventilated, when passively ventilated, sedated, and paralyzed? Is it considered normal for that condition? Or what is the difference from their normal, right? Like you mentioned, if anybody with chronic, like a fibrosis, for example, we know coming in their compliance is horrible. We know in the community it's horrible. And half the time when they come in respiratory distress, their compliance is not necessarily different from the community. It's just their gas exchange is altered due to an infection or something, and they're just working harder to do it and can't maintain it. But the compliance of the lung hasn't been altered from their infection at that point. Perhaps mechanical ventilation would assist in making it worse. If this patient is clearly that difficult to manage, they would likely require high driving pressures, etc. But yeah, it's one of those things that it'd be amazing if we knew what everyone's normal was before they came in the ICU, but we never do. Sometimes we know if they have outpatient stuff done recently, but
yeah,
not generally. Anyone want to comment on this classic graphic?
I put that on there just because it's sort of something I use when I teach about this topic. And obviously the left side of that, as you're looking at that graphic, the left side of that graphic is what a normal alveolus would sort of look like, and the right side of that graphic, where there are some people on this in the audience there and on this panel that are really facile with inflammatory markers and TNF and all cytokines. I am not, and I just like to say that, look, again, this is what happens to these patients isn't normal. They get an insult, whether or not it's direct or indirect, primary, secondary, pulmonary, extrapulmonary. If you look at the literature, people describe these things differently, but whether or not it's primary or secondary, it's a massive, over-exaggerated inflammatory process that's not normal, and that inflammatory process makes the alveolar capillary interface leaky, and you get all this, all these inflammatory markers. And these inflammatory markers circulate systemically, and sometimes will bring in multi-system organ failure, where you may have started out with primary single organ failure from a primary ARDS, and now you're beating them up with the ventilator, and you cause this secondary inflammatory process that then brings in other organ systems into the fray. I think it's interesting to note, and during one of our panel discussions, we showed a slide that talked about mortality. And again, a good paper to look at is a huge observational study, the LungSafe trial that showed that no matter where you're at in the world, you could be in Charlottesville, Chicago, doesn't matter where you're at. Moderate to severe ARDS has about a 40% roughly mortality rate, give or take. And of that 40% of ARDS patients that don't survive, only 1 out of 10 of those patients that don't survive actually die from hypoxia or hypoxemic respiratory failure. And a large number of these patients, I won't say a majority, but a large number of them, that's what got them intubated, right? Was hypoxemic respiratory failure and work of breathing. And so if only 1 out of 10 of those people die from hypoxemic respiratory failure, the other 9 or 90% die from multi-system organ failure. So we don't know what percentage of that multi-system organ failure is caused by secondary inflammatory processes caused by the ventilator, but I think that it's safe to say that some of it is for sure. So, it's important to remember that if you have single organ failure, primary pulmonary respiratory failure, that you can easily shift that into multi-system organ failure with the ventilator. And we'll talk a lot about that in part 2, or when we talk about different ventilator strategies and volumes and pressures and things like that. But that's sort of the crux of management of these patients.
And it underscores the ARM trial, right? It underscores the importance of proper ventilation settings. When I say proper, that's up for self-definition. That's up for however it's defined at certain institutions. But we all know for a fact that the ventilator can hurt our patient. And like Keith said, if we're going to continuously hurt our patient, this is not going to get any better. I mean, this is why we're kind of stuck, like Keith said, at a nearly 40% mortality rate. So
yeah, I posted a link to the LungSafe study, which I believe is an open access article, and I highly recommend people look at it because you may or may not be shocked as to how horrible we were following ARDS guidelines across the globe. One of the very interesting things from this study is that this was 3 years after ProSeva was published, showing that there was a significant reduction, like the highest we had seen in ARDS study in mortality. So significant reduction in mortality using the prone position in patients with PF ratio less than 150. And in the LungSafe study, it showed that only 16.3% of patients with severe ARDS were utilizing prone positioning. So I would like to hope, and I believe there may have been some follow-up studies since COVID looking at this, but maybe not to this grand scale of 500 ICUs across 50 countries. But I would think that after COVID, that number has gone up significantly. I think the threshold to prone from a comfort level has been eased a little bit through the experience many places got through COVID. But prior to COVID, it was significantly underutilized despite the evidence showing that it provides benefit.
But there was, and I don't know how old this was, and you guys may be able to help me out, is that Brower and his colleagues, I think they showed at Hopkins, one of the premier institutions in our country, had a 42% compliance rate when it came to lung protective ventilation strategies in these patients. So, we still struggle clearly, I think, not only in the United States, but around the world, as maybe evidenced by the LungSafe trial, that we still struggle to maintain these proper ventilation settings or ventilator settings on these patients. So
yeah, the LungSafe study really illuminated our just suboptimal ventilator management. And I don't have it in front of me, but the percentage of clinicians that checked plateau pressure on a somewhat regular basis was very low. Also, recognition of ARDS was very low. In other words, when they did chart audits and looked at data in the chart, the EMARS, the term ARDS wasn't showing up. And now this was all, it seems like it was just last month, but I think that was that 2016?
Yep.
The lung safe, I think.
Yep.
Yeah,
2016.
2016. I mean, that's almost 10 years ago now. So, gosh, it makes me feel pretty old. But there it is. I mean, we were doing a horrible job, and I'd like to think that we are doing a better job now. Another interesting perspective.
Just to highlight some of those things that you were stating here. This is, for example, this is the patients in whom plateau pressure was measured. This is the percent. So if you look at all invasively, but if you just look at controlled patients, because that makes more sense, this is severe ARDS patients. So just under half patients with severe ARDS were having their plateau measured. This is severe up here. So looking at a cohort of 557 patients. So yeah, they weren't even measuring plateau in any reasonable fashion in terms of I would honestly hope, and I assume that this has actually gotten better over the years since COVID, because there was such a push to monitor driving pressure to understand the context of the severity of the patient, that probably plateau pressure was measured, or at least the maneuver was performed more regularly.
Yeah. And even if you remember, this hasn't been that long ago, but if you remember Gattinoni's phenotype paper, yep, and how, there were two phenotypes, maybe more, of COVID-19 ARDS patients or COVID-19 patients. And I think the compliance of 20 that you were talking about earlier may have been part of Gattinoni's description of one of the ways to sort of separate the two phenotypes.
Yeah, they had discussed an H and an L phenotype for high and low elastins. The problem with that definition at the time is that many of the patients, for example, in the early stages of COVID, they were getting intubated quite early based on hypoxemia. And so some of these patients, or at least some of the questions, even when these papers were published, was, we don't have a definitive data to rule out that it wasn't just a timing aspect that created the low elastance group, or the high elastance group, sorry. So the patients with worse lung conditions, they weren't entirely sure if it was a timing standpoint, because some patients would come to the hospital very early, others would wait at home because they were terrified to come in. So by the time they come in, they now have an L type, but perhaps they've been at home with just worsening lung conditions. So I think it was hard to determine whether or not this was a true phenotype. Having said that, there's other phenotype papers that look at inflammatory mediators and everything, and even look that there clearly is a difference in how patients respond during mechanical ventilation. There was another phenotype study just looking at ARDS criteria, and definitely compliance was different between two phenotypes. And this wasn't the COVID one that we were talking about, but I know you and I were on a live panel during the early parts of COVID where we were describing these things, but trying to be very careful not to say this is how it is. We're this is what's being reported.
Yeah,
we're still not sure if this is a progression. Yeah, it was so early, but we tried very carefully to say, we don't have significant data to rule out whether or not this is a progression or a time element that distinguishes the two patients, because even the ones with the low elastance could develop into a high elastance scenario. So one phenotype doesn't mean they fall in that category forever, right? So
because purportedly, if you're managing the patient correctly, and again, we're not going to get into this now, but you're doing things that improve compliance, right?
Or at least maintain it until the lung starts to heal.
Right.
Perhaps. Yeah. All right. Who wants to talk about this one?
Sure. So this is this is the same. This is the two images, a multi-dimensional image and a single dimension chest X-ray of the same patient in the same time frame, and you can see that although that chest X-ray is certainly what we like to say, it ain't normal, it ain't natural. It certainly doesn't give you a real good picture of what's really going on as the chest X-ray does. I mean, the CT, the high resolution CT scan does. And so I like to show those two pictures next to each other because it really, the CT scan really shows you the involvement, the diffuse involvement that you might not appreciate quite as much by looking at the chest X-ray. This image here is of a patient that I had years ago. It was a young female patient that had leukemia and got intubated. Of course, very immunocompromised, and got about every kind of bug that you could possibly imagine. And this unfortunate person did not survive. But the reason why I'm showing you this CT scan is because it's really impressive. And you can, your first thought is, what is that? But when you realize that it's the thorax and the lungs, this poor thing, we had to we cannulated for ECMO, obviously. And we had to put her on a neonatal circuit with an adult ventilator because obviously we were having problems with volumes. And anyway, so this is, anybody seen patients like this?
Not for long.
Yeah. This is sort of this is a kind of a rare image, to be honest with you. It's sort of a rarity, although we see things that are, maybe not quite as bad, but similar, like the previous CT scan. This is a rare image. I have another rare image I use sometimes in lectures that is of esophageal intubation. You don't see images of them very long because it either gets fixed.
Right? It's corrected quite quickly.
Corrected before you actually have time to get a chest image, or it can't be fixed, like this one right here.
Can you go back to the previous slide real quick? The previous check. There you go. I think just to highlight what Keith had said, on the cross section of the CT scan there on the right, that the aerated portions of those lungs are, what Laurent Bouchard and Gattinoni described as kind of the baby lung. And it's important to emphasize for those maybe not in the respiratory community or for those who don't run mechanical ventilators, and please forgive me, Keith, for jumping forward about management with these ventilators, but these are the lungs you don't want to hurt and that you don't want to over-distend, because then you're just going to add injury to insult and your patients are going to get much worse. Whereas in this case, if you put them on smaller tidal volumes and you accept those pHs of 7.25 or less, then maybe you can get these folks some lung rest and get them better. So I think it's very important to really recognize what these patients look like on CT or on chest X-ray, so that you're not saying, well, the ideal body weight is 72 kgs, so I'm going to put this patient on 500 cc's of volume, when in fact they probably don't need 500 cc's. They probably need closer to like 350 or 300 just to keep them safe.
Yeah, and this highlights the complexity as to why we still don't know the best way to select PEEP, because the areas that you see that are open, that John just accurately described as the baby lung, those areas don't need PEEP. They're open, right? So to try and open the other regions with PEEP, you put the baby lung regions that are already open at risk of overdistension. So because the other areas would require excessive pressures normally to combat what's going on there, the areas that are already open, you hope that if you can improve the compliance of all the other areas, that the potential for injury in the baby lung is reduced. But this comes down to recruitment potential. And if the patient doesn't have recruitment potential, then that pressure that you're applying is just going to overdistend the area that is currently the healthiest part of the lung.
I think this makes a great case for the advantage of slow incremental PEEP titrations, so that you can give the patient time to respond to your changes as you evaluate the mechanics.
Yeah, agree. And so as if all of this wasn't complicated enough, the patient doesn't even have to already be sick to be exposed to ventilator-induced lung injury, right? There is some, and we'll talk about this again in part two a lot more in depth, but there's, people, part of what we want to talk to today are people that are at risk for ARDS, not just get put in your lap with ARDS, right? The people that there's intraoperative data now by anesthesia groups that show, who are typically sort of late to adopt new ideas, at least in my professional lifetime here, where they used to use real low levels of PEEP or no PEEP, real high tidal volumes. But those guys now have seen that, the patients that go in the operating room that are there for a couple of hours, intubated just for the operation, were not sick prior to, that come out de-recruited, they come out with some lung injury, et cetera. So, in our mission to describe the etiology and the definition of ARDS and possible, risk factors, just being intubated is a risk factor for ARDS. Getting a massive amount of volume resuscitation is another risk factor. Getting massive amount of blood transfusion is a risk factor. Being intubated is a risk factor for microbes from above going down into the lungs and causing an infection. So just being intubated at all is a risk factor for experiencing ventilator-induced lung injury.
I think that's a great point, Keith, and why I think, and kind of Madison mentioned she worked at a place where there's a little bit quicker trigger to put the breathing tube in when criteria are met. I think the reason why places like mine, and I'm sure other places for people on the call, have a little bit more hesitation is because of everything you just mentioned, right? I mean, it's not that they don't identify that they're sick. I mean, they obviously know that they're sick, but if they're, their PO2 is above 60, even on high levels of oxygen, and they're still awake and their work of breathing appears manageable with the assistance of the non-invasive device, they're less concerned, I guess, or they're, more concerned about what will happen if they do intubate them versus leaving them like they are and hoping that some of the other therapies kick in before they get bad enough that they have no other choice.
Yeah. Yeah, that's if it was easy, everybody'd be doing it, right? It's very complicated. It's complicated, and it takes a team working together to look at the patient, voice their concerns, voice their reasoning, and not intubating too early, not intubating too late. Just they can try to make good decisions.
We got 8 minutes left, Keith. Would you want to go through this stuff?
Yeah. So let's look. Let me.
And if I'll just point out too, if there's any questions, you can put them in the chat. There's a few sort of comments that we can address either now or at the end. I don't know if you want to go through this outline first.
Let's go through this real quick, Thomas, and then we'll field questions that come up. So etiologies and risk factors. We have already talked in depth about the definition. What does it look like, et cetera. PF ratios, imaging. What causes it? Again, it's an inflammatory process. It can be caused by a direct. You'll see in the literature, direct, primary, pulmonary, whatever. But those are things that happen initially to the lungs themselves. Most popular, it's very unpopular to be honest with you, but most common is a viral or bacterial infection that the lungs experience directly. Aspiration or gastric contents and pneumonitis that causes huge inflammatory cascades, near drowning, other inhaled sort of smoke or toxic gases. Indirect, most common is sepsis. So you have sepsis, and then the lungs get involved via circulation of inflammatory mediators from sepsis. Trauma, pulmonary contusions, aspiration and trauma. An underappreciated one, which we've seen quite often, is transfusion-related lung injury and ARDS, which can be from massive transfusion protocols or lots of blood transfusions. Pancreatitis, some of the sickest patients that I've ever helped take care of have had ARDS that were that were sort of caused or initially were a pancreatitis patient. A couple of those really come to mind fairly quickly, but in the name of time conservation here. Transfusions, drug overdose, you get the picture. Like anything that can cause an insult of any kind, like any kind of insult to the human body, can trigger a massive inflammatory response based on the patient's susceptibility to that and the seriousness of the insult. A couple of the newest things, obviously, we saw a lot of ARDS during the COVID-19 pandemic. Something that's sort of newer is the e-cigarette or vaping etiology of ARDS. And finally, risk factors. The older you are, the higher risk you are at developing ARDS. Survival from ARDS based on age is kind of an interesting phenomenon, and I'm not sure that I know for sure we don't have time to talk about it right now, but it's worth looking into, and maybe in part 2 we'll talk about that. Smoking, anything that causes you to be that have chronic sort of dysfunction, pulmonary dysfunction, or so that could be anything like pre-existing lung disease or smoking, where somebody may have obstructive disease, but they're kind of teetering, and they're not really chronically that sick, but they have some deficit in terms of their pulmonary function. And obviously somebody who has CF or interstitial lung disease or anything like that would be at a higher risk of developing ARDS. So kind of went through that quickly, but I think that we should all have the picture now what ARDS is, what it looks like, and then what causes it. The clinical presentation and diagnosis, obviously these patients, not everybody, remember the happy COVID patient, the happy hypoxemic patient. Not everybody looks horrible when they're sick. Symptoms, but the majority of patients will be dyspneic, tachypneic, will have a high work of breathing, will have the other findings that you would find in a sinus, an hypoxemic patient. Chest exam will be very similar, crackles, accessory muscle use. Imaging is a really important thing. I think that we will talk in part 2, we're going to talk probably about EIT and bedside imaging and how that might help with some of these recruitment type approaches, PEEP titration, etc. ABG analysis. I say this every time I talk about any of these topics that we have these panel discussions on. I don't know how useful an ABG is to me to take care of a patient. I know that people sort of rely on them for some aspects. I think I can see what I need to see with the patient enough to do most of the management that I need to do.
Probably the most common relevant thing now would be for determination of prone positioning, like essentially
Right.
just to
Right.
just as the as a trigger, or as a maybe we don't need to do it again kind of thing. It doesn't always work, and this can be a discussion
Right.
for another live. But just wanted to point that out that might be one reason.
That's a perfect. It would be really hard for me to make an argument to not do a blood gas on somebody who you prone to. But I don't think would stand there in front of the team and say, I don't want to do a blood gas on this person. I agree with you 100%. I will say, and John sort of touched on this a few minutes ago, there's been a pretty significant paradigm shift since we really started to think about protective mechanical ventilation, and whether or not, we no longer try to shoot for a pH of 7.40 or a PO2 of greater than 80. And so that paradigm shift has, at least in part, been caused by us understanding the damage that we are doing with the ventilator. So in part 2, we put this part of the outline on here, but this is all going to be in part 2, mechanical ventilator management, prone positioning, fluid management, the etiology. Obviously, when somebody's bleeding to death, the fix to that is to stop whatever's bleeding. If somebody's dying from a massive infection, then obviously the fix to that is to fix that infection.
I thought Ventolin was for everything.
Right?
Salbutamol
It
fixes
is.
everything, doesn't it?
Well, we're still going to give the albuterol regardless, but
Yeah.
And we'll talk about emerging therapies and research directions. That being said, Thomas, are there any questions that people have that we need to get to?
There were some things that were clarified in the comments just by myself or Madison. There was just some comments. I just wanted to make sure we didn't miss any of the comments, at least answered. There was one thing about rule of thumb for intubating, but we kind of, Madison and I just sort of added some clarity to that. One of the comments was the goal of the SPFO2 may be to raise a red flag that more aggressive therapy, or for example, an ABG is warranted. I think this is a reasonable reason to use it in a resource heavy scenario, but in the resource limited scenario, this might be all you have to really, and this is why this sort of came about and is more included, is that some places may not have readily available ABGs in resource limited settings. So this could be a replacement for it. But in regular clinical practice in resource heavy centers, this definitely could be something as a red flag that perhaps we should draw an ABG. I don't know if anybody agrees or disagrees with that, but I feel like that's probably more reasonable when you have the resources for an ABG. It could be a flag, but if you don't have it, this might be the replacement, and that's what they're sort of suggesting.
Yeah, I find when I calculate the SF ratio and I do a blood gas and calculate the PF ratio, that they're similar enough to me, at least in the bell curve, right? There are going to be outliers depending upon the physiology of the specific patient. I find that they're close enough that I get the idea. And I
think it all depends on what you want to use the PF ratio for. Like, what is it going to change your therapy? And this is where it came down to the only thing we can think of where it may influence therapy directly would be the decision to prone or to not to prone. Again, just if we're following the best evidence we have, then this would be the criteria for continue or not continuing. But otherwise, it could be a replacement, because if it's not guiding your therapy, it's just a matter of trending at that point. You just want to see if your patient's improving or if they're getting worse.
Right. And and to be honest with you, resource for places that are resource limited, I don't know that they would have readily available VV ECMO or not. But certainly, if you see a trend, and I prefer the OI which we'll talk about next time for that purpose. But for trending, Thomas, I agree with you 100%.
All right, we are 3 minutes over, but
okay.
There's just one comment there that people are definitely highlighting. It's that they get frustrated when they go run a gas, and just to know it's something we already know. And that's
yeah, me too. Me too. How many have you used in VBGs for acidemia? I mean, it doesn't tell you anything for you can't rely on it for anything. A real venous O2 is not useful, but
no. And even with acidosis, it does have limitations when the CO2, I think if I recall correctly, if it's above 50, then you may want to do an ABG. It's not a complete linear relationship between the VBG and the ABG. So if your VBG, I think VBG is great for trending minor changes you're trying to make. But if the VCO2, I believe if it's higher than, it's either 50 or 55, then it should be one of those flags that if you have ABG readily available, you may want to see how acid, again, and the pH is acidotic. You might want to figure out how it may be. Yeah, there may be more information to know. That was my sort of threshold when I used to teach VBGs to the nurses in the hospital, that if the VCO2 was significantly elevated, that this is maybe a patient you want to then get more confirmation, get an ABG, because it may be affecting oxygenation, et cetera. Who knows?
It does have a small place in there. I mean, for acid-base balance, for sure.
Yeah.
Yeah, I mean, so the interesting thing is it has a negative predictive value for hypercarbia, right? Your venous CO2, if your venous CO2 is not above 45, then your arterial CO2 cannot be above 45.
Right.
And pH is close, real close. And
Yep.
bicarb is real, serum bicarb is real close. So
Yep.
anyway, we use them a lot.
Yep. As I think they should be, because they're less invasive and can be drawn from lines that the patient likely already has, like IVs, et cetera.
Right, right. All right, well,
Good stuff.
good stuff, good conversation. Thanks for all the input from the participants. Madison put up our website web address. If you want to make sure that you get signed up for part 2, we have to find out availability for the panelists, and then we'll put up the date that we come up with for September's panel discussion. But go to the website. This episode will be available. The recording will be available here shortly, and you can also go to the website to get to that. So thanks to all of the panelists. Thanks to all the participants, and we hope that you've gotten something out of this discussion, and we will see you in September.
Thank you very much.
See y'all. Bye-bye.
So much. Bye-bye.